Yes, yes, please. Thank. Okay. Is it live now?
You're live now. You can start the session.
Okay, friends, good evening to all of you. On behalf of the Shankar Netrala Alumni Association and as the president of the Alumni Association, I have great pleasure welcoming you all for this third Shankar Netrala Alumni Connect series webinar. As you all know that Shankar Netrala Alumni Association is the strongest association in the entire country, and we are also very vibrant, very active. So I thought let's connect together with various subspecialties in ophthalmology. And about 4 weeks back, we started off with the retina potpourri, and we had a fantastic response for that as well. Then 2 weeks back, on the occasion of the World Diabetic Day, we had a diabetic retinopathy webinar and diabetic eye disease webinar, and for which we had excellent faculty, excellent talks as well. And today we have got a very, very important topic which is close to the hearts of many people in SN. Also, my mentor, Dr. JB, is there, who is the godfather for all of us as far as Uvetis is concerned. And we got some excellent speakers lined up. Dr. Manoj Khatri will be joining us, Dr. Partha Pritham will be joining us, and they'll be moderating the whole session. And this Uvetis panorama, we thought, okay, well, let's have a case presentation followed by a good discussion which can benefit not only the practicing ophthalmologists and also the UAT specialists as well, and also the residents and the postgraduates. So I have the greatest pleasure of welcoming two top people. One is Dr. Because JB, who is father of UATs as far as India is concerned, the world is concerned, and what we are as SN alumnus, SN students, we have we benefited from Dr. JB's teachings to great extent, especially me because I worked with close quarters with JB, and when he was also doing his fellowship and other things when way back in 80s and 90s. So JB, is a pleasure to have you here on this webinar.
Thank you very much.
And we are
Good
looking
introduction.
forward to your valuable inputs.
Thank you.
Of course, we have Dr. Kalpana Babu from Bangalore. Kalpana Babu is we are very proud to have Kalpana Babu as an SN alumnus here. And not only that, she is an authority in Uvetis, but she is also the president of the Uvetis Society of India. The Uvetis Society of India has grown leaps and bounds in the past few years. And we see that it's a very, very active, very vibrant group, and lot of discussions, lot of publications in this group. A lot of research is also going on in this. I'm very happy to have Dr. Kalpana Babu here to grace this occasion and give her valuable inputs, which will benefit all of us. And with these few words, I hand over, and I want um, uh, Dr. JB to say a few words, followed by Dr. Kalpana Babu, and then we can take it forward. JB?
I feel that it's a great idea to start uveitis panorama and particularly case-based discussion. Uveitis is often a challenging, a mind-boggling, and can often be vision-threatening. And many of the times we often miss the diagnosis of uveitis, even distinguished from non-uveitic entity, and to distinguish between infectious and non-infectious uveitis, what to investigate, how to investigate, how much to investigate, what treatment to start, topical, systemic, or periocular or intravitreal. These are often becomes a dilemma. What I felt most important is that it's important to distinguish between infectious and non-infectious uveitis. And currently we have got laboratory investigations, we have got imaging facilities, so we are better off than when I started. But still, we need to assimilate the findings and the knowledge to come to a proper and precise diagnosis and start prompt treatment because it can cause loss of vision. So this webinar, Shankaratala alumni is in the forefront of the clinical ophthalmology. So this is a good idea to start a kind of a panorama, uveitis panorama, which will benefit all of us, clinician, even uveitis specialists, junior, senior, as well as the postgraduates. With these few words, I like to hand over to Dr. Kalpana Babu.
Kalpana Babu, your words of wisdom, please.
Thank you, sir. And I hope Dr. JB said completely. And I congratulate SN Alumni Association for bringing uveitis to this forum. And though uveitis is a very niche specialty, it's no longer niche anymore because most of us do come across cases of uveitis in our daily practice. And hopefully this forum will, provide certain, tips for a common or a general ophthalmologist to look at these cases in more detail. With this, I hand over to Dr. Mohan Rajan.
Thank you, Dr. Kalpana and Dr. JB for your excellent words of wisdom. I think it's very important that you be, and as JB rightly said, I think if you look at all the uveitis specialists across India, majority of them, more than, in my opinion, I may be right, I may be wrong, I'm not sure, but JB will be probably able to tell you, more than 50% or 60% are from Shankar Nethralaya. So the reason why, and that's the reason I think it's because of the JB's influence and the impact what he has created over so many years. And JB, we are very thankful to you. We are really blessed to be associated with you and with our alma mater, Shankar Nethralaya, which you are benefiting. And uveitis is always a challenge. And we are going to see some top uveitis specialists who are going to give some excellent presentations today. So let's start off with the.
Sir, just we'll have one
Yeah,
word.
Manoj. Yeah, Manoj. Yes.
Salil sir is there, sir. Salil sir.
Salil is come. Okay.
Doctor
Salil.
sir, just few words from you, sir, before we start.
Salil Mehta. Hi.
Hi, Shalil. Hi, Shalil.
Salil sir, you are unmute yourself, sir, please. Salil sir.
I think everything that needs to be said has been said. So let's get on with the show.
Hi, Salil.
Hi.
Hi.
Okay, so here we are on one of the biggest platform, as everyone said, that SN Alumni uveitic webinar is always very exciting. It's not about exciting cases, it's more so about the exciting discussion which happens followed by that. And let's move on to the first talk by none other than a dear friend, Dr. Hitesh Sharma from Mumbai, who will be sharing his challenges and telling us how to overcome that. Hitesh, are you ready with your present?
Yes, sir. Thank you, sir, for the kind introduction. So, I would like to thank SN Alumni, JB sir and Partho sir. I'll just share my screen. Is it visible, sir?
Yes.
Yes, it's visible and you're audible. Just full screen. Yeah, that's it. Please go ahead.
So I'll present one interesting case which I had recently seen. So I'll start off with my case. So my case. So 49 years old healthy male presented to us in December 2023. He is non-diabetic, non-hypertensive, and complained of gradually progressive painless loss in vision from OU, OD more than OS since around 2 weeks. Patient gave 12 years history of hepatitis C virus infection and no other systemic complaints. So on examination, the best corrected visual acuity in the right eye OD was 636 N18 and in OS was 69 N6 with a quite anterior chamber with a clear lens and a normal IOP. However, after dilated checkup, this was the fundus photograph, where you can see bilateral disc edema with multiple hemorrhages and cotton wool spots around the disc, and macular edema with hard exudates and subretinal fluid at fovea in both the eyes, right eye more than left. So on OCT, which showed the subretinal fluid and the hard exudates at the fovea, which was more as compared to the left eye. So this is the left eye OCT and the right eye OCT. So we did an FFA angiography. So on angiography, there were not many signs which we could see apart from the disc leakage, and periphery seemed to be normal with no major leak. So this is the right eye, and there was disc staining and disc leakage and probably an enlarged FAZ. So this is the left eye. Again on angiography, there was disc staining, disc leak, which was little less than the right eye, but a more or less normal peripheral retina and the vascular arcades. So the first probable diagnosis which we normally see, we could think of common things. So we measured the blood pressure. So blood pressure was absolutely normal at various occasions. Patient was an media professional, but he didn't complain of any, didn't give any history of blood pressure, or even the blood pressures were normal. So then we investigated, and CBC, urine, routine, LFT, RFT, all were normal. And HIV, syphilis, toxo was negative, non-reactive. And TB and sarcoid, tests for TB and sarcoid were normal or negative. But the patient gave history of taking combination of direct acting antivirals, DAA medications, sofosbuvir and velpatasvir, for the past 8 weeks as a treatment of his previously untreated or treatment naive HCV infection. So we went through the literature, and there have been some cases documented of uveitis post treatment with direct acting antivirals. So we discussed with the physician and requested him to stop the DAAs, and we had given him 1 gram of IVMP followed by intravenous methylprednisolone, followed by tapering doses of oral steroids. So at follow-up of 1 week, there was slight decrease in the disc edema, but more or less the hard exudates had increased in the right eye, and he was kept under close observation. At 2 weeks, the disc edema definitely, especially in the right eye, was seemed to have reduced down, but the hard exudates were very close to the fovea in the right eye. So this is the OCT at 2 weeks. So you can see there's still a lot of fluid, and there were some damage to the outer retinal layers. So as the vision didn't improve much, vision was same, and there was consistent CME, subretinal fluid and hard exudates which were close to the fovea. A dexamethasone sustained release intravitreal implant was injected on 11th January 2024, around 3 weeks post IVMP, and stopping DAs. And oral steroids were slowly tapered. So follow-up at 5 weeks, that is 2 weeks post Ozurdex, there was slight reduction in the hard exudates, and the disc edema was seemed to be resolving. So this is the OCT picture. And follow-up at 2 months, the disc edema was almost resolved, especially in the left eye. However, the macular edema, the subretinal fluid was still persistent. So again, he was treated along with oral steroids, some topicals also, and there was an implant in the right eye. So at 4 months, the disc edema completely resolved, and the left eye was looking at almost normal, apart from the thinning and some hard exudates in the right eye. So if we see in the OCT at 4 months, there was thinning and there was structural damage to the fovea, which was correlated to the persistent vision loss which was there in the right eye. However, the macular edema and the subretinal fluid completely resolved in the right eye, and left eye was more or less normal. So our probable diagnosis was like bilateral optic neuritis like picture, probably secondary to direct acting antivirals, sofosbuvir and velpatasvir. So discussion and literature, DAAs are now the gold standard in treating chronic HCV infection, as it is effective and curative in most patients. A 12 weeks course of these agents can cure more than 90% of HCV infections, depending upon the HCV genotype. Sofosbuvir and velpatasvir is the drug of choice for treatment-naive HCV infections without cirrhosis or with compensated cirrhosis. So this combination of sofosbuvir and velpatasvir acts against all these 6 genotypes of HCV infections. So literature review, sofosbuvir has been documented to cause impairment of tear function and metaplastic changes on the ocular surface of patients with chronic hepatitis C infection. Katrina et al. Have documented case of bilateral non-granulomatous uveitis and retinopathy following ribavirin and sofosbuvir. Padidam et al. Noted posterior predominant uveitis in a series of patients post-treatment with ledipasvir-sofosbuvir combination for chronic HCV infections. So they had noticed vasculitis in 8 eyes and papillitis in 7 eyes and cystoid macular edema in 6 eyes in these 6 patients. So conclusion, our patient who was treated with a combination of these direct acting antivirals presented with bilateral posterior segment involvement resembling neuroretinitis like picture 6 weeks after initiating the treatment. After ruling out all the possible common etiologies and observing improvement following discontinuation of the direct acting antivirals, we suspect the inflammatory reaction was induced due to the medications. Based on the literature review, we postulate that sofosbuvir is the likely agent responsible for the inflammatory reactions, as it was the common drug which was common to all the literatures. So larger studies are, however, needed to confirm this association. Thus, ophthalmologists and physicians, especially hepatologists, should be aware of these potential side effects of these commonly prescribed medications. So these are a new drug of medications which are highly effective and would be more commonly used as more and more cases of HCV would be diagnosed, and they are very effective. So more than 90% have been treated with just a few weeks course of these medications. However, we should have more data and everyone should be aware of the potential side effects of these commonly prescribed medications in these conditions. So I would like to thank my teachers from RIBHU and Shankar Netralaya. Thank you.
Very good case, Hitesh.
Very
Really an eye-opener, actually.
Yes.
Can't even think that antivirals, systemic antivirals can cause this kind of a presentation. We'll definitely hear more from the panelists, but just wanted to tell you on that SRF. So the SRF, this kind of chronic turbid SRF, this is more like a turbid variety of SRF. We don't get an immediate response. We have to wait weeks to months together with any kind of therapy, whether it is anti-VEGF or steroid, intravitreal steroids. So just wanted to add on that point. Over to you, Dr. JB sir.
I just wanted to make some general comments and then specific comments. General comments, as I feel like in uveitis practice, it's very important to spend time with the patient at the beginning itself before you start looking at putting the patient on slit lamp or indirect ophthalmoscopy. The history taking, the files which he has brought, the records which he has brought, and what the drugs he's taking is very important. It's important to the past history or any of the disease which is harboring, he or she is harboring, is quite important. I don't keep any target of finishing my OPD. I feel that as a time request for each patient, I need to give that amount of time. This patient history has been well taken and the culprit drug has been identified. And there are several drugs which can produce uveitis, you know, that starting from the biphosphonate and all, they produce pan-uveitis and can be vision threatening and can mimic infectious or non-infectious severe uveitis. Stoppage of the drugs is important. Looking at this, if I didn't have the drug history, if I heard of disc edema in both eyes, I would have done an CT scan or MRI of the brain to rule out the disc edema, cause of the disc edema. That I would have added to this my approach in uveitis. And it has been rightly investigated that fundus photography and fluorescent angiogram, ultrasound is quite important to find out any kind of a like BKH like lesions where you can have disc edema. But this particular patient is rightly put on IV methylprednisolone. Any time of disc edema, papillitis, IV methylprednisolone is a very good choice. And prolonged macular edema that can be treated well with the sustained release implant. That is also, I feel, is quite justified. Giving oral steroid would have taken a long time. What is very important is that sometimes the macula becomes thin, retinal thinning occurs, and this often causes loss of vision in spite of successful resolution inflammation. These are my points. Kalpana.
So
Hitesh,
we had done MRI, so which was normal, sir. So I forgot to add that.
Okay.
so
Okay,
Hitesh,
Dr.
this is a really nice case. And while while you were talking, I also managed to do a little bit of scrolling. So the most complete series I found so far is by one lady called Padidam, however you pronounce it. And she has described 6 patients.
So same I have
Have you
added in
put
my
that over
series.
there?
No, it's mentioned there. Yes.
Yeah, it's mentioned
As
there.
mentioned.
And out of that, papillitis is seen in 4 patients. So this does fit the definition of papillitis with macular edema, which is definitely there. But unfortunately, in this particular article, they have not put any color photographs. So you can't compare as to whether it is a similar type or it's a dissimilar type. But if I didn't have this history, my first possible diagnosis would have been Bartonella.
That's what I was thinking.
My
Yes.
first diagnosis would have been Bartonella, and if I could not get proof of Bartonella or any of the other infections, then I would have even investigated for APLA, just to be on the safe side.
I wanted to just comment on the case in the sense, see, for me, it didn't look like uveitis actually. This looked more like a retinal problem actually. So this patient had optic, like a papillitis kind of picture with a lot of cotton wool spots around the disc and a lot of hemorrhages with some subretinal fluid bilaterally symmetrical. And the first thing which it gives is an impression of Persianness, if I may call it so. And many of these antivirals generally have a tendency to cause anemia and blood hematological abnormalities. Basically, your blood parameters gets deranged. So in your case, all these were in the normal range. But interestingly, there are lots of things like pancreatitis can develop in these patients, and these could be acute in nature. And these can incite this kind of an, inflammation, what you are seeing, like this kind of a ischemic event kind of in the eye. So for me, it didn't look more like optic neuritis. It looked more like something related to a retinal problem. And because even on the OCT, you're not seeing cells. And definitely because of the disc edema, as the edema is resolving, you're seeing subretinal exudates which are coming in.
Sorry, I missed the anterior segment findings. Were there any? Did you have KP cells there? Quiet,
so anterior segment was quite.
Okay.
So I think I would also look at hematological abnormalities in this case. I mean, to be on the safer side.
And peripheral blood smear we had done and routine, and he didn't give any history, any systemic. We tried to
What was the vision?
Vision was 636 in the right eye and around 69 in the left eye.
See, for optic neuritis with this kind of picture, generally you would expect a poorer vision. So my thing would be more in favor of hematological issues which have caused this retinal parameter. So maybe you can also look at with protein like protein C, protein S, and kind of hematological abnormalities which can give you this in the setting of an antiviral drug or a combo drug, which can cause other issues like pancreatitis or even hepatic involvement. Sometimes you can have this kind of a drug.
What is the age of the patient, Nitesh?
So for 49, 50.
49.
So, because I would tend to agree with Dr. Kalpana, because I work very closely with a hematologist who is next door actually for us, and he refers a lot of patients like this and very typical pictures like this leukemia, this myelodysplastic syndromes. And so what he normally does is, apart from the hematological investigations, he also does a bone marrow biopsy for all these patients whenever we send it across to him to make sure that everything is fine. Yeah. But how does the DAA Act produce this? What is the mechanism of action?
So for
You said the optic neuritis.
Hepatitis C virus.
DAA.
These are antiretroviral, I think they're retroviral drugs also, right? In terms of
they are directly acting antiviral
Directly
agents.
acting antiviral.
So what is the mechanism of
It acts on the DNA.
no idea.
So of causing these eye problems.
no, the optic neuritis, whatever you mentioned, no, here.
Not sure, sir.
Huh?
Not sure, sir. How?
Not sure. Okay.
Because in all these series, it is like typically after 6 to 8 weeks. This is the typical gap. Like after 6 weeks to maybe 8 weeks and 12 weeks, these cases have presented, and they have like
Maybe
similar.
I, maybe
And he gave this typical history of
I'll guess.
around having these symptoms around that time only.
So if his vision is good, did you get fields done or did it make any difference?
Sorry, ma'am.
Fields?
Field, no, ma'am. I don't think so. We did field.
Okay, Tish, thank you so very much for an interesting case. As always, it's a pleasure listening to you. You come up with something new every time.
Thank you.
Yes. So as we are have pan uveitis, we also have pan India coverage. So from Mumbai, we will be moving to Guwahati now, and we will be having Shubham Sinha Roy talking to us with his interesting case. Again, a dear friend from Guwahati, who will be hosting Vitretina Society of India meeting about in a couple of days' time. So
Yes.
over to you, Shubham, for your interesting presentation.
Good evening, sir. Good evening. Good evening, everyone. It's my pleasure to be on this platform to present on case actually. So I'll directly go with the case, sharing my slides. So my slides are visible, sir.
Yeah,
Yes.
visible
Yeah,
and
yeah.
you're audible. Just
Slide
keep it
show.
slide
Slide
show.
show.
I'll just do.
Yeah.
Hmm.
Please go ahead, Shubham.
Yes, sir. So this is a very unique case to me because as a retina specialist, I was not very keen to see this uveitis cases often on. So this was my first case with this interaction with this entity as a consultant when I started my practice here in Guwahati in Shankar Dev Netralaya. So this was a 32-year-old male who was an IT professional who presented to us with a sudden onset diminution of vision in both the eyes since last 4 to 5 days of onset. And he had a history of fever with a rash 1 month ago, and he was treated locally by his physician with a presumptive diagnosis of typhoid fever, but he had no other systemic illness other than that. So, when examination and finding his right eye was a little better compared to the vision acuity with a search of the right eye was 6 by 18, the left eye is finger counting close to face, the anterior segment was normal, IOP was in normal limits. Let's come to the fundus evaluation right now. So if you see this right eye, so the right eye, if you see posterior pole looks okay, but the two arrows that I'm pointing out, you can see here in the inferior arcade, the first arrow, there is some pale yellowish deeper lesions. You can see the vessels running over it. And the second arrow that is at the inferior arcade, you can see there is a little whitish lesions involving that vessels and all that hemorrhages around it. So it looks like more a keratinitis lesion in the right eye, the inferior arcade, and the first arrow that indicates some sort of choroidal lesions because the lesions are more deeper. And now coming to the second eye, which is the worst eye, and you see this second eye. So a lot of lesions, a much angry looking second eye. You can see that mostly in the posterior pole, all the changes that you see here. And if I point out my arrows, the first two arrows that detects the vascular arcades and the superior arcade and also superior nasal arcades, you can see that creamy yellowish lesions, little deeper lesions, as you can see the vessels running over through it, retinal vessels. And also the posterior pole, you can see a little whitish lesions, more deeper, more superficial also, and are associated with hemorrhages. And you can see the disc edema, the disc is blurred, hyperemic disc. And here at that end, the last area, you can see that you can see a clear demarcation line, which is nothing but a large neurosensory detachment, which is involving the posterior pole and also progressing inferiorly and also nasally. So this picture and with this background, we have gone for further investigations. We did the OCT. You see the OCT in the right eye, you have sharp retinal fluid at the fovea. Other than that, the retina looks okay. But in the left eye, if you see that arrow pointing out, you can see the lesions that you're seeing in the posterior pole. It is involving the entire length of the retina. The whole retinal layers are involved, which are more opacification of the layers. You hardly can detect any layers in the retina. And the second arrow, they points out a lot of vitreous cells, which suggest inflammatory pathology to us. So going a little deeper to these lesions, if I run this video in the right eye, where that lesions were in the right eye in that inferior arcade, and you see in that inferior arcade, if I pause here, so right at this point, you can see that whole of the entire retinal length is involved and there are a lot of SRF around it and a lot of vitreous cells overlying these lesions. And as you go above towards the fovea, the lesions are coming down, but there is a pocket of SRF at the fovea. So coming to the left eye, so if you see, if you start from the inferior arcade, you can see a lot of neurosensory detachments here. And as you go towards the fovea, the lesions are involving the entire length, the entire thickness of the retinal layers, a lot of SRF and a lot of study to the vitreous cells there. So at the fovea and also at the posterior pole. So with this information and the findings, we decided to go ahead with the further FFA and ICG. But unfortunately, the patient develops even nausea with some vasovagal attack during the procedure. So you have to abort the procedure with successful resuscitation of the patient, but you could not go ahead with the FFA and ICG with these patients. So with this information, we have tried to investigate the patients. So we started with the CBC, ESR, CRP, ruled out everything normal. The Monto and TB test, quantiferon HRCT was normal with the normal limits. Even the serum ACE was done. We tried to detect a well Phillips reaction because he had history of fever with rashes. To rule out any rickettsial involvement, it was non-reactive, non-positive. Even VDRL was non-reactive. HIV was 1 and 2 was non-reactive. So finally, we decided to go ahead with the PCR for the vitreous aspirate, to rule out any viral involvement the patient is having. Because most of the time, if you do an ELISA, it is very non-specific in the blood. So even the aspirate for the PCR was negative for the results for the viral markers. So at this point, actually, we had no clue actually what we were dealing with. But considering the involvement of this, particularly the left eye, we're very worried what we're missing actually. So we reinvestigated to go back to the case and we decided, discussed and talked to the patient. He was a bachelor living in a rented house in the Guwahati and an IT professional. So on detailed evaluation, you could elicit some sexual history of the patient in the past, and he is living with his partner in this Guwahati. And then we just re-emphasized the further test has to be done. So we repeated the VDRL, and the VDRL came out to be negative, and also repeated the HIV. But again, this time we have detected the TPHA, which came to be positive, with a ratio of 1:320. So we have decided to look at the CD4 levels also. So the lymphocyte profile, absolute CD3 count, CD4 counts, which was coming to be the normal range as per the patient profile. So with this information, we have re-evaluated our diagnosis. So we detected a case of a posterior uveitis, probably secondary to ocular syphilis. So we also referred the patient to physician to rule out a neurosyphilis also, because as ocular syphilis, mostly involvement of the neurosyphilis is much common. So we treated the patient, the discussion with the physician. We have started with the injection benzathine penicillin that time, 2.4 million international to 1 IM once a week for 3 weeks consecutively. Along with that, we also patient received a capsule doxycycline 100 milligram BD for 2 weeks. And we decided to start with the steroids, but at that time we are not very sure what actually we're dealing with. But I was a little hesitant to start immediately, so I waited for a week. So this is the picture after 1 week of the just immediately after treating the patient with the benzathine penicillin. And if you see the both the eyes in the right and left eye, particularly the left eye, how nicely the regions have started regressing, all the deep retinal lesions. You can see now patchy opacities of the retina in the posterior pole. Even the choroiditis lesions are also in the arcades getting much fading away. The disc edema is getting much better than SRF. The most important component, that huge SRF that was seeing in the first picture, it is coming down. Now, at least in the left eye, we can see the foveal architecture is coming back. We can see now the shallow SRF fluid, pocket fluid in the left eye. And also in the right eye, you can see that the SRF is coming down, the lesions and the inferior arcade, the retinitis lesion, it is also now started resolving. So at this point of time, I started the patient on oral steroids when I met sure that yes, and being a syphilis patient in a syphilic case when the ocular involvement. So after 1 month of the therapy, so if you can see the right eye, almost the lesions are vanished away. You cannot see any probably any active lesions in the right eye. The fovea has become compact. And in the left, you can see all the patchy choroiditis lesions and the retinitis lesions has faded away. The disc edema is much better. You can see that you can see now see the entire border of the disc. The SRF is almost completely regressed. A very shallow film you can see in the fovea. The foveal thinning you can appreciate now. That outer layers are thinned out. That ellipsoid and the photoreceptor layers are disrupted. So we continued the treatment with the slow tapering of the oral steroids and took care of the disc edema. And this is the case at the 3 month of follow-up. You can see in the yellow arrow at the right, you can see the retinitis lesion, which is completely scarred, and there you can see a gliosis at that area. The fovea is completely compact. And the left eye, you can see that completely all the lesions have disappeared, almost a little temporal pallor you can see in the disc, but overall the entire integrity of the disc, that margins of the disc are much clear. And if you see the OCT, yes, there is a foveal thinning, but the ellipsoid zones are disrupted, particularly nasally. But what is important is patient regained his vision back. So right eye is now 6 from 618. The left eye, which once you thought you almost lost the left eye, it has improved to 6.9. So this was a very, very eye opener to me, because previously I was not very used to see these syphilis cases, particularly as a retina resident in Shankar Nethralaya. So when I started dealing and go outside and dealing with these cases, sometimes it becomes very challenging. So this was my journey with this case. So I close my case and open for discussion. Thank you.
So truly, really fascinating, Shubham.
Fantastic.
So I think if I had seen this and if I had not taken the proper history, my first impression would have been dengue. Something
Actually,
very
that was the
similar.
point.
Or some
I wanted.
form of post-fever retinitis in any
I
case.
would also have thought of post-fever retinitis.
Yeah.
That's the same things that I thought. Even I have
Ah.
even well Felix reaction and also other things was negative. Dengue
Oh.
was not there because he told it was treated by physician and all. But
Shubham, can
I
you
was little.
stop sharing the screen for a minute?
Yes, sir. Yes, sir. Yes, sir.
Yeah, okay, fine. So that we can see you. Yeah.
Yes, thank
So
you.
Oh,
the other
wonderful.
thing is, was his partner male or female?
Uh, so he told he's a female, but
Uh,
initially he was hiding all the histories. So I
uh,
was very skeptical that what I was missing, because VDRL was non-reactive, and initially I was not giving both this like FTPH or FTA in the same time. So I was
right.
using VDRL as a initial screening,
So,
and based on that I was going for other test.
so
So
in fact,
nowadays
Dr.
I
JB
changed
will
my protocol.
Dr. JB will back me out, and Kalpana will back me out, and Dr. Mukesh Jain also will back me up. That last week we had a outstanding uveitis meet in Singapore, and the one thing every person who came on stage to talk about their cases, everybody said the same thing. No matter what the sex, no matter what the partner, no matter what the age, TPHA and VDRL is now compulsory for every patient of uveitis that walks into your clinic, even if they deny any kind of history.
That's
Yeah.
why I
It should
changed my
now become
protocol.
like
So now I
CBC.
give.
It should now become like CBC. It has to be done for everyone.
Absolutely.
I
And so
just
here
want
in
to,
northeast part of India, I'm getting a lot of
JB sir wants
syphilis
to comment.
cases.
Yes,
I
JB
just
sir.
want to
Yes.
tell you that some classification now, each uveitic entity, to label it as like a peak or a intermediate uveitis or serpiginous choroiditis, everything you need to rule out syphilis. that has been put that to one of the point that is universal. We have become fooled of several times looking at the patient and then appearance of the things and the age of the patient that the patient cannot be syphilis, even the clinical picture. And I've been befooled a number of times. And I had a one patient who came with a exudates in the one looks like pars planitis. And I asked the history of that one. The patient said, "Uncle, I have never gone to bad ladies." Then later on, his HIV was positive, syphilis, VDRL, TPHA was positive. And I don't want to bother the patients with personal history so much. That's not my habit. But this time I probed into it, and that patient had said he has sex with a male patient, male partner. And this man having sex with man having very high risk of syphilis, ocular syphilis. And syphilis can befall you, can present any kind of uveitis. And
Right.
it's good that you have detected rightly and in right time. And then what is most important is that syphilis is one of the disease where the treatment is so much rewarding. So not unlike Basets or any other uveitic infection, it's so much gratifying to get the treatment and
Right.
make the patient all right. Congratulations.
So
Thank you,
if
sir.
he tells you that I have never been to any bad ladies, you must tell him, but bad ladies may have come to you.
Other way around.
Other way around.
Very nice. Very nice. Wonderful. I
Only
think
thing is,
really
so
fantastic.
the availability of the penicillin nowadays, because it was a case 2 years back, and now the penicillin availability,
Benzathine and
particularly in this
penicillin
part, is
G both are in short supply.
yes,
Yeah.
sir. So
So you have
nowadays
to,
our
in the end, you have to
physician,
You can
use,
give ceftriaxone.
you have to give
yeah,
ceftriaxone.
ceftriaxone and doxy now they are giving, sir.
Yeah.
Mm.
Wonderful case.
Dr. Kalpana, your comments?
So I agree. Actually, I would have thought this as post-fever retinitis, and many times post-fever retinitis settles down on its own. But what was interesting is the duration of improvement. Like we saw it in a week's time, I think,
Yes,
or
sir.
two
Yes,
weeks' time.
1 week time,
This
ma'am.
much of a thing I never see with post-fever retinitis. Generally, it's about 6 weeks or 2 months or so. So that was something unusual in your case. The instant improvement to benzathine, penicillin, and then the steroids, unless there was some injection or something given before. But this tremendous improvement, generally, we don't see with
Even
post-fever.
that's why, ma'am, I have not started steroids initially because I have no idea what way I was going. So after 1 week when we saw this improvement, then I've started steroids.
Interestingly, there is something called a prozone phenomenon. So you can have a VDRL negative
Yeah.
in these cases. So that is something which we need to keep in mind. And the fact that TPHA only was positive is something like, it could have been a previous infection and we don't know. I mean, kind of, it could be thing. So, but anyway, the eye opener for me was the dramatic improvement, which I wouldn't see in such a short span of time with post-fever retinitis.
I think now the gold standard is we should do FTA-ABS, that is
Yes.
fluorescent treponemal antibody studies.
Mhm.
So those are much more reliable. And VDRL is used only for follow-up monitoring.
All of
If
the
your
best.
titer keeps dropping, you know that the drug is working.
I'm just wondering if there was a role for RPR in these cases.
RPR also is done sometimes.
As well.
RPR is also very
RPR titer.
non-specific.
RPR is also
Yeah.
just
In the
anti-cardiolipin
context
antibody, so
of
it's non-specific.
in the context of TPHA positivity, if we had looked at the RPR titer also,
Then I think
maybe it might.
FTA-ABS is the best.
Yes, best.
TAA-based.
Treponemal test.
No, I was just have a question for Shubham and also the panelists here. If suppose the TPHA was negative and all the syphilis tests were negative,
Hmm.
how we would have treated this patient?
First is to do a FTA-ABS. That is the most sensitive of this lot.
Yes.
Generally,
I would have just given steroids and left it at that.
Basically, sir,
Absence of infection, what do you do?
so because everything is negative, but there's a lot of inflammatory component on your OCT, like you are
Yeah.
seeing
Yes,
cells,
ma'am.
you're seeing fluid. So my first line would be to start him on oral steroids. And if it comes down, fine. If it doesn't come down, then nowadays we inject with anti-VEGFs or Ozurdex you can use in these cases because the fluid comes down. And if it's post-fever retinitis, it will settle down anyway. The OCT looks scary the minute you see it, but if you
It
see
looks
them 3 months
terribly
or 6
scary.
months down the line, you see a good vascular perfusion. And we have reported it also recently. There's a reperfusion, and that's the reason why their vision is generally good, unlike other forms of retinitis where the vision goes down.
Sure.
Once the retinitis and the fluid comes down, the vision automatically improves. That's because the vascular remodeling occurs in the foveal area.
No,
I
Kalpana,
I would
just
have
want,
treated the patient with steroid, even
yeah.
IV steroid, but not to prove me anything, I would add oral doxycycline also.
Yes, ma'am. That
Because
was, I was
post-fever
initially I
retinitis.
was thinking if syphilis was negative, I'll put a doxy along with oral steroids because taking as
No, yeah.
infectious.
No, I just wanted
That's
to
very non-scientific thing.
when you are suspecting, of course, when all the tests are negative but underlying infectious, but is it not a good idea to not a good idea to inject Osidex inside, because oral steroids, suppose there is a worsening, you can always withdraw and stop. But
Yeah.
once you put an Osidex inside, suppose there's an infectious component that can get aggravated, no?
So usually this is
Yes.
more, we've started believing, at least before the era of doxy, earlier also we used to treat with steroids and it would settle down by itself in 2-3 months' time. So, but nowadays, because of query a rickettsial component, generally
Yeah.
we treat it with doxy. So the first line is, of course, oral steroids, but if the fluid is quite massive, it generally doesn't settle down fully with oral steroids. So at that point of time, we do give anti-VEGFs. That will be the first one, because sometimes you do see occlusive components also, and they land up with NVDs also. And still it doesn't settle down, then you can probably keep Osidex in line. But it takes time, sir, for the vision to recover
Yeah.
back.
Very nice. Excellent.
Okay, thank you so very much, Shubham, for an interesting case, as always. Now
Thank you,
let's
sir.
move on to a person from City of Joy, a very joyful person, Dr. Mukesh Jain. Mukesh, are you ready with your case presentation?
Yes, sir, I'm ready.
Okay, please, can you go ahead, start your screen share?
Is my screen visible and
Yeah,
am I
visible
audible?
and you're audible. Please go ahead.
Yes.
Good evening, everyone. Thank you for this wonderful opportunity. I'll be presenting an interesting case. The title of my presentation being that Dice Don't Lie. So, my case is a 55-year-old lady who presented with gradual progressive diminution of vision in both eyes, more in the left than the right, since last 3 years. She is a known case of rheumatoid arthritis on tab Folitrix 10 mg weekly and is well controlled systemically. She had multiple consultations elsewhere and had received a short course of oral steroids 2 months ago, and she doesn't have any known other systemic comorbidities. Her best corrected vision in the right eye was 6/24 and left eye was 2/60, and anterior segment was normal. There were 2+ vitreous cells in both eyes. So coming to the fundus photo, as you can see, there's presence of vitreous haze, and in all the 4 quadrants, as you can see, presence of perivascular cuffing, and this cuffing looked more chronic than active. Similar finding was noted in the other eye also, with presence of perivascular cuffing, and that was also chronic. Before lab, and the OCT was showing presence of foveal thinning more in the left eye there was loss of outer retinal layers in the left eye, explaining the poor vision in the left eye. So before labeling it to be secondary to rheumatoid arthritis, we worked up the patient. Her blood counts and biochemistry profile was normal. Her syphilis workup was negative. Serum AC was normal. MUN2 was 6 mm. IGRA and HRCT was negative. So with that in mind, we wrote a referral letter to the rheumatologist who increased the Folitrix dose from 10 mg to 15. And with that, we topped up with oral steroids 60 mg and tapered her slowly over 4 months. So when we see her after 4 months, her vision remains the same, 6/24 in the right eye and 2/60, and the AVF cells have reduced. She is presently on 10 milligram visolone and 15 mg Folitrix weekly. So as you can see, this is the fundus photo at presentation, and this at 5 weeks. The media has cleared significantly, and the vascular cuffing also has reduced significantly. Similarly, similar findings were noted in the left eye. So at this point, to know how we should titrate our treatment, we went ahead with a FFA, and to our surprise, what we found, there was a hot disc with large vessel leakage and fern-like pattern in the periphery in the right eye, and similar finding was also noted in the left eye. We knew that we are dealing with something that we cannot wait, so we spoke to the rheumatologist here, and she was started on rituximab infusion, and 3 doses were given over 5 months, and oral steroids was restarted at lower dose of 40 milligram. So when she came after 5 months of follow-up, you can see the fundus looked relatively stable with similar finding as that noted 5 months ago, and minimal vitritis with perivascular cuffing, which were chronic looking. So at this time, we wanted to stop the biologics, and we wanted to keep her on Folitrix and oral steroids as we were tapering it down. So we repeated the FFA, and what was very surprising that there was hardly any change in her FFA. It was a hot disc with leakage of the larger vessels and similar or rather increased perivascular capillary leakage in the right eye, and similar finding were noted in the left eye. And on OCT, we can see there was presence of some cystic changes now in the right eye, and the left eye was almost the same as before. Now we are puzzled. We actually do not know, and this angiogram was done just 2 weeks ago. So what is next in line? Should we add MMF to the above treatment? Should we add an alkylating agent or a T cell inhibitor? Or should we go ahead with Ozurdex injection or something else? So when we did a review of literature about our case, we found that in rheumatic diseases, retinal vasculitis is relatively uncommon and has not been studied much. And what was very interesting was that we found this, that in many patients, this clinical signs of vasculitis may be not evident on clinical examination, and FFA might be necessary to know the extent and severity of it. So to conclude, the take-home message from my presentation being that rheumatoid arthritis can be associated with retinal vasculitis, though uncommon, and fundus finding may be subtle at times. Dye-based imaging gives us a global information about what is going on, and aggressive management is required, including biologics, IMT, and combinations. I would like to thank Anindya sir to help me in this case. And before I conclude, I would like to leave you with these 2 questions. What interval should we repeat the FFA in such cases? And second, we always keep saying that Octa will replace FFA, but I know that dyes don't lie. Thank you.
I'd just like to add.
Wonderful.
So, Mohan, really, really interesting case. So, Mukesh, I don't want to sound critical, and you've done a great job in following up and doing all the necessary investigations. But if this patient came to me, my first thought would be, I am missing the etiologic diagnosis. I would really strongly think in terms of an underlying infection, possibly viral. And the first thing I would get done is most labs now have something called as an immunocompromised viral panel, where they do CMV, HSV1, HSV2, VZV, EBV, and they detect it by PCR from a single blood sample. So different labs call it different names. But this is the first thing I would do, because I think that the reason the thing is not settling down even after 5 shots or 3 or 5 shots of rituximab is because the underlying infectious agent is not being controlled. And the papers that you showed of those authors actually mean rheumatologic diseases, as in autoimmune diseases which fall under the purview like auto AAV, C ANCA, P ANCA, not specifically rheumatoid arthritis, what we classically define as rheumatoid factor positive and anti-CCP positive. Those primarily tend to be anterior segment disease. It's more of a scleritis and an episcleritis rather than anything else. I really think you need to get back. It is my opinion. You need to get back to this patient and speak to the rheumatologist, and you need to get a basic or at least a very advanced workup done to see whether she has a systemic viral infection, which is really possible because she's been on Folitrax for a very, very long time. Yeah.
But
And there
Salil,
is simple.
I would like to add the dose of Folitrax which she was on is very low. It's about 10 mg per week what she was on. Is
No,
she
but
a
most
known case
patients
of
get only
rheumatoid arthritis?
7.5 to 10 a week anyway. That is
No,
the standard maintenance dose.
no. 10 is very low for
Very
rheumatoid.
low.
Very low for rheumatoid. And is she a confirmed case of rheumatoid?
Yes, ma'am. She's a confirmed case
Rheumatoid.
for last 20 years.
So in these cases, generally over time, they develop a vasculitic component. Now the features, what you actually showed was disc edema, there is retinal vasculitis, and there is foveal atrophy as well. So these are actually normally signs which we generally see with intermediate uveitis and chronic intermediate uveitis over a period of time. These cases actually generally the dose what she is on, the methotrexate is very low. And I wouldn't put these patients on rituximab. My choice would be probably adalimumab first. And if it doesn't settle down and I'm still seeing cystoid spaces, tocilizumab is a better option, provided I rule out tuberculosis. Because the way I'm seeing the, involvement, it's vasculitis along the retinal veins mainly. And arteries are relatively okay in this case. So usually my first choice after I've ruled out TB and if I get an ANA and ANA is negative, would be first adalimumab. And if it is not settling down with adalimumab, generally I would prefer tocilizumab. Tocilizumab works excellent for rheumatoid arthritis. So refractory cases of rheumatoid arthritis, we do give tocilizumab. And leakage with cystoid macular edema is one indication where we do give tocilizumab. And they've done well. We've published one, but that's not with RA, but this is an intermediate uveitis. When they develop macular changes, they do a good job.
I think before starting rituximab, I'm sure the rheumatologist must have done, no? At least HRCT with Mantoux and
Yes, sir.
quantiferon gold.
Mantoux was 6, I think.
Yes, ma'am.
Yeah.
It was 6. IGRA
So
was
that was done in the past, or was it done just prior to starting rituximab?
No, we did it, sir, when she presented to me that time, and then the Mantoux was repeated before starting rituximab.
Correct.
And the decision to start rituximab was taken by the rheumatologist. The choice of biologics was by the rheumatologist, not
No,
by
Does
no,
she have
that is
any other
perfectly okay.
vasculitis elsewhere in the body for them to start rituximab? Because rituximab is not a drug which they would start for RA unless there is a component of vasculitis associated elsewhere in the body.
Yes, sir.
So
That's true.
usually rituximab is the last because they don't have anything beyond rituximab. So the option, they all do well with adalimumab first. And if it doesn't settle down with adalimumab, then the tocilizumab will be a better option.
I like to tell that one that I had a patient of seronegative rheumatoid arthritis who had got exactly similar picture. And that patient responded very well with injection adalimumab subcutaneously. But however, the patient had reactivation of tuberculosis and we have to stop adalimumab. And then I put the patient on mycophenolate mofetil and prednisolone. The patient is doing extremely well and she's very grateful to me, to us, Shankar Nethralaya. And I would, the clinical pictures of his, it didn't look like to an infective retinal vasculitis to me, like, disc edema and disc leakage and the retinal vasculitis. So if we infective vasculitis, we see more first coughing, that very prominent coughing of the thing, and we see frosted branch angiitis like picture. The viral retina, and there will be retinitis component. Here we don't see any retinitis component. We see a vasculitis, and is a 50-year-old, 55-year-old female, and is on, I think that Folitrax was not adequate dosage for sure. And the patient, if it is on adequate dosage of methotrexate, it would have been responded well with that treatment. I would go with that hiking up the methotrexate first to 20 to 20, even 25, and then if not responding, put on the adalimumab. If not, I will add JAK inhibitor, which also is a good drug for rheumatoid arthritis.
Ma'am, in these cases, like what would be the end point, or maybe to hike up the steroids? Because these cases, these are chronic in spite of repeating angiography again and again. And if you don't see clinically inflammation, maybe these angiography will show some amount of leakage and these furning patterns.
See,
So when do we decide that we have to maybe uh, hike up the methotrexate more, or maybe add adalimumab, or shift from adalimumab to rituximab or something?
So here I would like to differentiate two things. One is, are you looking at an idiopathic intermediate uveitis, or are you looking at something where there is a cause in the body, like rheumatoid arthritis in this? So here there is definitively a cause, and that can cause this kind of a pattern in spite of being on treatment with methotrexate, or so you can develop a vasculitic component with time. So probably in rheumatoid arthritis, I would probably treat them with biologics. Whereas if it was an idiopathic intermediate uveitis, I would just look at the OCT for macular thickness. Is the thickness changing with time? And if there is development of cystoid macular spaces. So if there is a development of cystoid macular spaces, then I know I have to treat these patients. Otherwise, they'll land up with foveal atrophy. Whereas if it is the macular thickness is more or less the same over a period of time, not changing much, then I would still like to watch with conventional immunomodulation. So generally, we do give a combo, methotrexate or mycophenolate, or I feel in my experience with idiopathic intermediate, they do very well with azathioprine. So this is idiopathic intermediate uveitis. But in his case, it's a case of rheumatoid where there are a lot of other components which play. So then I would be looking at the disease per se, where you can develop scleritis, you can develop vasculitis, even when they are on conventional immunomod. So for the rheumatologist, the disease is under control. His CRP is okay, ESR is okay, everything else. But for the ophthalmologist, you're seeing progression of scleritis, or you're seeing something like unusual like this pattern here. So in such cases, then probably I would ask them to switch over to a adalimumab or tocilizumab. Tocilizumab works very well for these cases, but because it's a very expensive drug and you have to give it IV, generally that will be my second, after adalimumab, we would look at it.
I would not have gone to rituximab.
Yeah,
Rituximab
rituximab
is a
little
B cell
unusual.
antibody. B cell acts against B cell. Weakness, or if it is
Connective tissue disorders like SLE works well.
SLE, we would go for rituximab.
Actually, rheumatoid arthritis, basically you have two components. One is the initial, you have a granuloma formation where that's the period when TNF is quite high. And this is the period you normally see scleritis, nodular scleritis, all that. But when you start seeing melts in the sclera, in rheumatoid arthritis, that's when we normally look at a vasculitic component in rheumatoid arthritis. Generally, when you see a vasculitic component, it is not only in the eye, you will see elsewhere in the body also. That is when they give rituximab. But generally, it is usually TNF mediated. And that is the reason TNF and IL-6 mediated. And that is the reason our first choice is adalimumab and then tocilizumab for refractory cases.
Very nice.
Okay, great case, Mukesh. Thank you so much for sharing it. Let's move on to another interesting case by Dr. Nitin Kumar, all the way from Jammu. Nitin, are you available?
Nitin,
Yes, sir. Yes, sir.
please
Nitin,
share your presentation.
we have physical meeting USA next year in Jammu. Not abhi. Abhi webinar karo aaj.
Yes, sir. Yes, sir.
Yes, sir.
Yes. Is my screen visible?
Yeah, visible and you're audible. Go ahead, Nitin.
Yeah, thank you so much for this opportunity. I would like to thank SN Alumni Association and Dr. JB sir and Dr. PMR sir for giving me this opportunity. So, have we talked enough about RA? Let's see after this presentation. So, this is a 56-year-old female who presented to us in early September with chief complaints of pain, redness, and blurred vision in the left eye for last 10 days, which had increased for the last 2 days. This was up to such extent that the lady was not able to sleep at night. There was history of redness in the left eye, which was insidious in onset and was progressive in nature, associated with severe pain. There was no history of trauma, similar complaints in the past. Okay. So, as far as the right eye examination was concerned, the examination was normal. However, she presented to us with this thing in the left eye. There was the vision was 6/9, intraocular pressure was normal. And as we can see from the anterior segment photographs, there was 360-degree scleral congestion with a with a stromal corneal infiltrate, which was about 3.5 millimeter into 1.5 millimeter. However, on fluorescein staining, there was not any staining, no staining was there. And we can see this crescent shaped infiltrate at the superior limbus at 12 o'clock position. Fundus examination was normal for both the eyes. And so what we were dealing was with sclerokeratitis kind of a picture. And looking at the presentation, we had to identify whether it was an infectious or a non-infectious kind of a thing. The infectious kind is more common in cases of trauma. It is associated with necrosis and presence of any discharge. However, in our case, there was uh, no discharge or any nodular kind of a presentation. Neither were there any pus point kind of a thing. And non-infectious is mostly associated with systemic diseases, but is less commonly seen with corneal abscesses kind of a picture, which was seen in our case. So coming to past history, the patient was having a history of hypothyroidism for last 6 years and was a known case of seropositive RA for last 20 years. However, she was on and off medications and recently had been started by a rheumatologist on methotrexate 15 mg, adalimumab, and hydroxychloroquine as well as sulfasalazine. But we have to dig deep into the history. She told that she was taking these medications for quite a lot of quite a for a lot last some months. But did she actually was taking this? No, she had stopped her biologicals and methotrexate recently. At this point of time, when she presented to us, she had some systemic findings also. There was a new crop of lesions on the flexor aspects of the flexor aspect of the limbs, and there were these deformities also. Am I audible? My screen is visible.
Yes, you are audible. Nitin, just make it full screen.
Yes.
Go ahead.
A skin biopsy was also performed. We had sought and dermatology consultation, and a diagnosis of psoriasis was also established at this point of time. On X-ray, there was severe ankylosis with sclerosis of intercarpal and carpometacarpal joints. So, as we had a um, as we had seen from our examination, this was more of uh, a non-infectious kind of a scleritis along with keratitis, and there were because the patient was not taking her medications for last few days, last few weeks in a sense, and this is the reason she might have landed up in this kind of a presentation at this point of time. So we started her back on oral steroids 1 mg per kg body weight along with topical steroids, and restarted her on adalimumab therapy 2 weekly. So this is just after 2 days of starting her back on oral steroids. we can see that there was decrease in the scleral congestion and the infiltrate has started to shrink. This is after 5 days of presentation. Everything has almost cleared up, and this is about 2 weeks after the presentation. We can see the scleritis has gone, and this keratitis has also healed in a very good manner. So there are also very limited kind of these cases with presentation of scleritis, keratitis, and rheumatoid arthritis with psoriasis also, as was seen in our case. To conclude, RA can be associated with psoriasis and the various ocular manifestations which are common. Immunosuppression is central in preventing recurrences, and it is always essential to rule out infectious scleritis in patients in RA who have been on immunosuppression for a long time. I'd like to acknowledge my residents for their help in this case, and thank you so much.
Very nice case, Nitin. Lots to learn. Dr. Kalsa Babu, your opinion?
Yeah, I would actually, Nitin's such beautiful presentation actually. So whenever we see a patient with scleritis, we not only look at whether it is necrotizing or non-necrotizing, we also look at if there is a peripheral corneal involvement, which is very important because the type of treatment we give will change accordingly. So we need to be more aggressive when the peripheral cornea is involved. And you rightly showed that corneal infiltrate. So basically what it just shows is there is ischemia to that area. So there could be a vasculitic component as well in this particular case. Fortunately, settled down beautifully with adalimumab. If it was something else, I would have probably looked at rituximab. I mean, the way we differ in our management, I mean, two separate cases of RA. But generally, rheumatoid arthritis is well known to improve with adalimumab. My only question was it really psoriasis what you were seeing in the leg, or was it a vasculitic component what you were seeing in the skin?
So,
No,
ma'am,
actually,
Explain the eye findings as well.
so actually RA and psoriatic arthritis very often coexist. And in fact, numerous autoimmune diseases tend to coexist anyway because the basic immunological system itself is misaligned or haywire, if you can use it colloquially. So to have RA and psoriatic arthritis, psoriasis both in the same patient is not unusual at all. In fact, it's fairly well known. So that's okay. That can perfectly be explained by this. But the histopath, I'm sure, must have been quite conclusive. So I don't think that there's a.
on histopathology, it was psoriasis.
Yeah, I don't think there's any
Because
doubt
the
about that. But
characteristic
very nicely
infiltrate
done. Very
is
nicely done.
generally we seen when there is a vasculitis associated.
My only question was that in the early few days of our treatment, we had only given steroids. It is after only some first week we had only give steroids. On steroids only it responded very well, and later on we added adalimumab. But ma'am, is it common to have these kind of stromal abscesses only without any uh, epithelial defects or typical involvement of PUK?
We usually see this with SLEs and ANCA related, like P ANCA, C ANCA related. The peripheral cornea gets involved more often in these cases with or without scleritis. So the way it works in these is the pathogen, the way connective tissue disorders are antigen antibody related, or ANCA, which is immune complex mediated related. In rheumatoid arthritis, it is rare, but it is not unusual. I mean, you do see in those cases which are not treated adequately earlier, or if they are non-compliant with medications. And in rheumatoid arthritis also, over a period of time, in spite of treatment, they can develop an element of vasculitis, like what we see with connective tissue disorders or ANCA. So that's when you have the peripheral cornea which starts getting involved.
Yeah, so I would not use the word scleral.
So this is not
Abscess.
sclerokeratitis. It
This
is
is more of
keratitis
scleral.
with peripheral corneal involvement.
Yeah,
Form
I
of.
just think of it as scleral inflammation, or rather as peripheral corneal involvement rather than anything else. I don't think there's any actual infection as such.
Is it a PUK?
Not
You can call
really.
it a
You
PUK?
can-
Because there's no
we have heard
ulceration. He has
space.
said now that there's no ulceration. It's just peripheral
Okay.
corneal involvement, just a thickening.
So, Dr. Mohan Rajan, generally you have three phases. Basically,
Yeah.
you will have a corneal infiltrate in the first phase. Then you will have like a
Yeah.
thinning of the cornea at that place. And then you'll have a gutter formation. That's when we call it
Yeah.
as a peripheral ulcerative keratitis, which we see with ANCA and all that.
Hmm.
But very nice case.
It's very nice.
JB
Seriously.
sir, any comments from you? You are muted, JB sir. You are muted, JB sir. JB sir, you are muted. Please unmute yourself.
Adalimumab is one of the drug which acts very fast, and you can see within 3-4 days there's a change of one. Yesterday I put the patients on adalimumab after the first dose itself. Is a case of Behçet's disease. He said I've started seeing the lights much more brighter, and he was almost hugging me for giving me this starting that new treatment. That patient is from Sudan, and this was quite a good experience for me. So you can get very dramatic improvement with injection adalimumab biologic agents.
Okay, thank you, Nitin, for an interesting case as
Well
always.
done, Nitin. Very nice.
Thank you so much.
Yeah, and all of us are coming to Jammu next year, okay? So we make
Yes, sir.
proper arrangements for all of us.
Yes.
Sir, welcome, sir. Welcome.
Okay, so let's move on to the our evening's next bright star, Dr. Molly Shah from Ahmedabad. And over to you, Molly, for your interesting case.
Yes, sir. Good evening, all. Thank you, SN Alumni Association, and Patho sir and JB sir for giving me the opportunity to present on this platform. So I would like to present a case that I had followed during my SN fellowship. This is an interesting case of a 50-year-old male presented with a complaint of diminution of vision in left eye for 4 months and loss of vision in right eye for 8 years. So he had history of trauma with wire in right eye 8 years ago. For that, he underwent corneal tear repair elsewhere. Left eye, he was diagnosed with bullous retinal detachment and suspected to have sympathetic ophthalmia elsewhere, and he was treated with pulse steroid, 3 doses followed by oral steroid. Since his vision did not improve, he came to our OPD, and on further, just a minute, my slides are not moving. On examination, right eye, he denied perception of light, and he had adherent leukemia along with complicated cataract. His his intraocular pressure in right eye was 3 millimeter of mercury. On left, his best corrected visual acuity was counter finger 2 meter in left eye with intraocular pressure 6 millimeter of mercury. There were fine KPs with shallow anterior chamber and complicated cataract in left eye. On dilated fundus examination, left eye hazily showed bullous retinal detachment, and we did ultrasound, we did USDB scan. It showed diffuse corneal thickening with exudative RD. So we decided to treat him with IVMP 3 doses followed by oral and topical steroids 1 milligram kg per day, and we also took the rheumatologist opinion and we started him on oral tofacitinib 5 milligram twice daily. So on follow-up after 2 months, his visual acuity improved to 6/60 and his IOP increased to 8 millimeter of mercury, but there was still SRF. So we continued him on oral steroids 10 milligram per day with tofacitinib. On 6 months follow-up, we saw that his visual acuity did not improve much. His intraocular pressure came to 12 millimeter of mercury, but he developed a complicated cataract. So we did ultrasound B scan and it showed retina was attached. Decided to take this patient for cataract surgery, and we did cataract surgery under steroid and tofacitinib cover. So this is a picture post-op cataract surgery, and his left eye visual acuity improved to 6/12. And on dilated fundus examination, we saw that it was a sunset glow fundus with peripapillary and juxtafoveal scarring, and there were bands of subretinal gliosis. We did SSOCT, and it showed that there were peripapillary and juxtafoveal CNVM, but on OCTA there was no flow in this, so it was more of a fibrotic tissue than vascular membrane. So we decided to keep him under observation. So this was a case where at presentation his visual acuity was configured 2 meter with IVMP and tofacitinib. It after 6 months it improved to 6/12. We could achieve at least 6/12 visual acuity with this. So tofacitinib is an inhibitor of Janus kinase 1 and 3 and has been reported to be successful in treatment of refractory scleritis, GI associated uveitis, HLV27 associated uveitis, and leakage. Though it is a small molecule, but its penetration is very good, and it reversibly binds with JAK proteins and downregulates production of cytokines. It is administered orally, so patient compliance is also better with this molecule, and so we can consider this to treat cases of sympathetic ophthalmia. Those are not responding to conventional therapy. Though there are no any case reports of tofacitinib use in sympathetic ophthalmia, but we had seen one case of leakage which responded to tofacitinib. So we decided to give in this patient too. Thank you.
Very nice case, Molly. Nicely documented as well. JB sir, your comments?
So today I have used tofacitinib for 4 cases. Of all the 4 cases was the anterior uveitis or scleritis. They do that respond very well. Non-infectious anterior uveitis, non-infectious scleritis. But I have not used for tofacitinib for posterior uveitis. I thought that that is a more severe inflammation, and where it might be. I was looking into the literature. There was not much literature on, no literature on sympathetic ophthalmia treated with tofacitinib. But as you know, it's a kind of a small molecule. It acts on the target pathway. So it would not be very surprising that it responded. And it responded so dramatically well. And with the cataract operation, there's a vision has gained significantly. So wonderful one. Congratulations. And this is a very well documented case.
Very nicely done, Mauli. So
Thank
again, sympathetic and ophthalmia and VKH are like literally, they are like Ganga Jamuna, Siamese twins. If you just see the OCT, you cannot make out what you are dealing with here. Do you have an OCT when you first saw the patient? At the time when there was just exudative detachments, did you try an OCT then?
Yes, we tried sir in SN, but we could not
No,
because there was
the
vitreous
detachments
haze
were too
and there
high.
was a bullous RD. So
They were too high.
yeah.
Yeah.
My only concern, Molly, with this case will be sympathetic ophthalmia requires lifelong treatment.
Yes.
So tofacitinib is not a drug where we have, we don't have data over many years because it has been associated with a lot of side effects and adverse events. Most common will be viral infections in these cases. So at some point of time, you will have to kind of remove the tofacitinib.
Yeah.
I would rather like you to be, like this patient to be on mycophenolate. Because that's more a safe drug. And you've already passed the aggressive phase. I would probably add or, probably discuss with the rheumatologist on switching back to conventional immunomodulation and keeping that for a longer period of time.
Yes.
Actually, one thing to ask, so because I am dealing with 2 patients, the VKH patients, both presented with a bilateral exudative RD, like similar case that she has shown. And I've started with the IVMP and full dose of all steroids, but I've started Azoran with them. So it's only 2 weeks back. So I have one eye is regressing better, other eye is little slow, but not that as compared to the other eye. And one patient responding very slowly. So my question is, what will be the first line of treatment in these cases? If to add a immunosuppressant in such cases, whether you should go for Azoran or like she has started Molly that like tofacitinib if straight away, or if you go for a mycophenolate in such cases, the choice of immunosuppressant along with steroids.
I
So
think the
how
conventional,
Salil,
yeah, I think the conventional teaching has always been the moment you see VKH, stroke sympathetic ophthalmia, IVMP is not enough. You need to start early cyclophosphamide. That has been the conventional teaching. I don't even know because now fears of sterility and teratogenicity and women are afraid of their eggs and men are afraid of their
I
little
disagree,
brothers. They are
Salil.
not willing not to take
No,
I would not go
cyclophosphamide.
cyclosporine.
Seriously.
we do very well with
Patient was
azathioprine or
already been
mycophenolate.
treated
No, I
with
think.
oral
I think
steroid
when
and
I
IV.
have
no,
azathioprine and mycophenolate, I would not go to
Yeah.
that
In
toxic drug,
fact,
Yeah.
cyclosporine.
yeah.
no,
So
no.
Yes,
the
I'm
way
just saying that was a conventional teaching when I did PG.
it's changed a lot, Salil.
Uh,
As you
Kalpana, Salil, and JB, and all the panelists, because I know I've been dealing with lot of this VKH syndrome patients. They're real. It's a different ball game, in my opinion.
They need two
I want.
immunosuppressants to start with.
Yes. No, what is the preferred practice protocols from your side? Suppose there is a VKH syndrome. How do we start? We give IVMP, oral steroids, then we start them on immunosuppressant. What is the first line immunosuppressants? What is the immunomodulator? There are several patients who are on Azuran, for me, mycophenolate. Still there's a recurrence. I've been following up these patients for almost 5, 6 years, 7 years. Continuous recurrence is there, back and forth with the rheumatologist and the ophthalmologist. So I just want to know is there any consensus on VKH?
I would give
I,
IVMP and as soon as possible start on mycophenolate mofetil. As soon as possible.
That will
I
be the
would,
first time.
I would, I don't know whether somebody to follow me or not. If I see a case of VKH, whatever the stage it is, I will give in that prednisolone 1 gram daily for 3 consecutive days and followed by either azathioprine or mycophenolate. Both of them are more or less same. I choose mycophenolate most of the time, 1 gram BD, and treat for 9 months at least with a tapered dose of oral steroid. I'll keep on 15 milligrams prednisolone for 9 months or more.
9 months.
Yeah.
Nine months.
The
Okay.
thing is,
9 months. 9 months tapering dose of oral steroids and 9 months as azathioprine also.
Yes.
usually these immunomodulators take time to work, sir. It takes about 3 to 4 months to start working. So these patients will require very, very slow taper. At least in our side, we keep it for us 6 to 9 months, depending on how the eye is. We also use a lot of combination therapies. Like we add methotrexate with mycophenolate, because many of
Yeah.
the patients don't afford biologics. So even with that, if they do not settle down, then that's a very small subset. Then we switch to adalimumab, and tofastamab is very. I don't think I have a case of VKH with tofastamab,
I
but
have also
generally
not
we
There
switch
is
done.
one
to
case,
adalimumab.
ma'am, I saw in SN that patient had bullous RD. No, actually, I read about it. That was case. There is
that
a
I have heard in the case
also.
report actually published,
Yeah,
I think.
yeah, that is published. So it responded very well with TOFA.
But
And
like if
no,
I have
no,
to
it
start on
should be,
Azoran,
yeah, definitely. This
then 50
was
milligram, I start as a TDS dose in the first month, then step up to
Then
BD and then OD. So in such executive RD, if I have to start 50 milligram TDS, I have to continue it for how long and then we have to taper to
Two
BD and
months, minimum 2 months.
So
minimum 2.
in
50
ours, we
milligram
give
TT for
MMF,
2 months or 1 month.
but you
JB,
need
Yes,
more than
2 months.
that. You'll need more than
50
that. You'll need
milligram
a
TTS
good
for one
dose
month
for
or
a
2 months.
long time. So we generally keep our patients at least for 2 years. I mean, it should be at least 1 year. They should not be using steroids, and then you start tapering it down. And we use
Ma'am,
up to 2 grams per day. That is our dose, which we generally use, and generally they have done well.
if you use azathioprine or cyclo, this mycophenolate mofetil, and it is not responding, when will you decide that this is resistant, or maybe you have to shift or to some other drug? When? And second, what is the role of cyclosporin? Cyclosporin I have seen very effective in especially cases of sympathetic ophthalmia.
Yeah,
So where there is extensive exudative retinal detachment, so those respond very well to cyclosporin.
so the only problem with cyclosporin is nowadays our rheumatologists are not comfortable with cyclosporin.
Yeah.
So because of lot of side effects because of the cyclosporin. So generally what we do is we wait for 3 to 4 months with the steroid is still on. But if they still develop recurrences even while they are on 4 months or so, or 4 or 5 months, then we add methotrexate. So start off with 10 and then increase it to 50. You can go up till 25. So it's a combination. And if it is still not working, then you're justified in starting biologics.
Thank you. Thank you very much.
Instead of waiting too long for that one, I
Yes.
think that the
Nowadays, they
injection
start earlier.
adalimumab can be given.
Yeah.
Injection adalimumab can be tried after 6 months not responding to the treatment. You can try injection adalimumab and see the response, because these are all immune-mediated uveitis.
Yeah.
You will
Sir,
respond
sir,
to.
it is very tricky, especially in one-eyed patient who is having sympathetic ophthalmia, and there is extensive exudative retinal detachment. You are not sure whether it is a combined or a plain exudative retinal detachment with shifting fluid. There could be a component of rheumatogenic
Yes.
tear or something. So, if at all there is some confusion and we are not sure, like, because whether to operate or not, that also at times there's a huge this thing.
You should
And
be a OCT to see the choroidal thickening. That
uh,
would be your
Scan we did to see.
scan ultrasound.
mhm.
CT, surface of CT to see the choroidal thickness.
But can we consider adding TOFA for short period? In such
Basically,
cases, if they are not responding, as tofacitinib is a small molecule, it can cross the blood-retinal barrier. It helps in reducing interleukin-2 levels, and it also acts on T cell like T cell immunity. So can we consider in future?
so
Like,
we
I
had,
have
I
much
was
add it.
for the
experience about for
rheumatology,
that.
they had a conference and one of the topic was stofacitinib, but the new steroid. So basically, everybody is starting to use it as the initial period. Unfortunately, we are seeing a lot of vascular occlusive events because
Mm.
of
Amide chances
stofacitinib.
of amide.
Yeah, we ourselves had a case of.
I have reported one case.
So ideally, we don't know much about the drug yet. So that will be my last choice, lest if you're in medical legal suit.
Thank you.
Thank you.
Manoj?
Yes, sir.
Yeah.
With any other comments or questions from the panelists?
I think it's a wonderful galaxy of cases.
Wonderful,
Very
wonderful.
nice.
Really
Galaxy
good.
cases
I
are-
learned a lot. I learned a lot. It was a master class on Uvetis, I would say. Master class.
Wonderful
Hats off.
galaxy of cases as pointed out by none other than our guru, mentor, Dr. JB sir. And we thank all the panelists, all the presenters who take out their precious time and sharing their insights with, the entire SN Alumni Association on this prestigious UVITS webinar. We will be having this kind of webinars every second week. And this is the third in the series, and stay tuned for many more learning on this prestigious platform. And with this, one more sincere request to all of you SN alumni out there to reach out to your wider circles of ophthalmology and make sure that next All India Ophthalmic Society elections, we have a duty to get our SN Alumni Association President, Dr. Mohan Rajan sir, to get elected for the post of AIS Vice President. He is contesting for the post of AIS Vice President 2025. The elections will be online, and it is our sincere request and duty of all of us to get as many votes as possible across India from all our circles. I know we have a lot of, wide circles in UVITS, non-UVITS platform. So please do reach out to your state societies, to your local societies, to your friends, colleagues across India, and make sure he wins hands down with a huge victory margin. So this is another sincere request on this prestigious platform from our side, especially from my side. Keep this in mind and sincerely start working on it from now on. We have another 4 months to go. So please
Yeah.
do keep this request in mind. And with this, I think we'd like to conclude this session. If there are no any more comments from
I
anyone.
want to say a few words, Manoj.
Yes, sir.
Thank you very much for this wonderful webinar, I would say, and really valuable inputs from JB and Kalpana, and all the speakers were really fantastic. Very rare, unique cases. I think it's a very nice discussion also. And I appeal to all of you to support me. I assure you all that I will take AOS to greater heights, make it more progressive, more inclusive, and covering every nook and corner of of our country. Thank you very much for the wonderful opportunity.
And so before I end up with, I would like to invite all of you for the upcoming VRSI, this time hosted by Guwahati.
I'm coming. We are all coming.
Yes, sir. Manoj sir is coming.
Yeah, we are all there. We are all
Manoj
there.
is coming. I'm coming. We are all coming there.
We are all coming. And next year, Jammu, be prepared. Nitin.
Yes, sir. Happy to host you, sir.
Nitin,
Yes.
see you in Jammu.
Yes, sir. Sure,
Hope
sir.
Jammu is safe now. No problem.
Sir, very safe, sir.
Very good. Thank you.
Thank you so much, sir. Thank you.
And in between, we have prestigious AIS elections coming up. Please do keep it in mind. Sincere
Yeah, I
request
think
from our side.
the high time that our Shankanetralaya alumni all show the solidarity. And we are the best, and we are the most active and vibrant group. And we should show the solidarity. It's now or never. So I think it's important that we all act straight away. Thank you very much.
Yes. Thank you. Thank you very much, everyone. And have a
Thank
great
you.
evening ahead. Thank you so very much.
Night.
Good night, sir. Thank you.
Right.